Hi, my name is Phoebe and I'm a PhD student at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. I'm here today to speak to you about a systematic scoping review that I've been conducting with my colleagues at King's College London and the University of Oxford. Our review is focused on patient safety problems in community-based mental health services for working-age adults. The background to the field is that mental health services have been omitted from many of the key publications about patient safety which have defined the field in the past 20 or so years. Patient safety models, definitions, and the literature have mostly been developed in the context of physical healthcare services. The good news is that we're beginning to see some evidence reviews which focus on safety in mental health services. However, several of these reviews have focused on inpatient mental health services only. Other reviews, which don't focus on a specific setting, have found very few studies which relate to community care. A more recent review focuses on safe transitions of care from inpatient to community services, but does not focus on the long-term community care journeys and the safety implications associated with these. It's vital that we gain a better understanding of what patient safety problems look like in community-based mental health services. This is where the majority of mental health care is now delivered, either via secondary care, community-based mental health services, or increasingly in primary care. We know that there's been a 55% reduction in mental health bed numbers since the turn of the millennium. Likewise, some 43% of community mental health services for working-age adults were rated as requires improvement for safety at the most recent CQC inspection. Safety problems, their causal factors, and effective intervention mechanisms are likely to vary across different types of mental health care setting. On this basis, our review will try to fill these evidence gaps by conducting a systematic scoping review which focuses on patient safety in community-based mental health services specifically. We used the methods described by Arksey and O'Malley to conduct our scoping review. To start with, we focused on identifying our key research questions, which were to understand the nature of the safety problems in these services, causal factors, as well as evaluated safety interventions. We carried out a systematic search across 5 different databases, followed by a grey literature search, as well as hand searching. Our studies were selected according to the following criteria. Studies focused on a working-age adult population. They had a patient safety focus and were conducted within community mental health services. And by this, we included secondary care community mental health services, as well as mental health care delivered to people living in communities in primary care services. Our screening process began with title and abstract level screening, followed by review of eligible full texts. A second reviewer independently screened 10% of records to check for consensus. We charted the study data, extracting and organising into key research topics. We then mapped contributory factors to the Yorkshire Contributory Factors Framework, an adaptation for mental health services. Lastly, we sought to summarise and synthesise our findings, and we carried out a preliminary evidence appraisal of the studies that we identified. Through our search, we identified almost 14,000 unique records. After title and abstract screening, we restricted our search period to the year 2015 onwards in the interest of feasibility, and therefore we were left with 5,000 unique records. Over 120 studies were then included in the final systematic scoping review, which may be subject to further updates. We identified 7 key categories of research, which I'll identify in the following slides. In terms of the studies that we identified, we found that these were of variable quality. We often found that the study population the care setting and intervention mechanisms were not well defined. Studies very rarely reported on the severity of harm caused by the patient safety problem, and we also found that few studies stemmed from low and middle income countries. The studies that we found reported on a small number of specific safety incidents and a wider range of potential hazards in care delivery. Our first category of evidence related to the management of patient risk of harm to self. Service user suicides were a key incident type that was raised within this evidence area, and several potential hazards in relation to care were identified as well. These related to the features of care in relation to suicide risk, the care that service users had received prior to suicide, the adequacy of suicide risk assessment and management, as well as a perceived lack of adequate treatment options for service users at risk of suicide. Several key contributory factors were identified relating to the hazards concerning suicide. Some of these included workload and staffing factors, where care teams were unable to monitor service users at the level required in order to prevent suicide or self-harm, and other issues such as support from other teams. Self-harm was another key type of incident under this evidence category, and another hazard identified relating to self-harm was the delay or failure to follow up by services. And again, workload and staffing factors were identified as a key causal factor in this relationship. The interventions for suicide and self-harm broadly targeted both of these types of incidents and can be divided into those interventions which are directed at services or staff and those that are directed at service users specifically. Examples of these interventions include risk assessment training for staff and care planning to manage risk. Service user directed interventions included dialectical behavioural therapy for reducing risk of self-harm. A final type of incident in this category related to self-neglect, and the corresponding hazard was failure to assess for service users' risk of self-neglect, and again, workload and staffing factors were implicated in this. Our next area of evidence related to the management of risks of violence and aggression. Two types of incidents were raised in this category, and these included risk of victimisation by others, as well as violence and aggression perpetration by a service user when unwell. As you'll see, care-related hazards were not identified in the evidence base surrounding risks of violence and aggression, and studies concerning interventions really related specifically to those patient-directed interventions. The role of services in reducing or preventing violence and aggression was not well evidenced. The third category of evidence concerned clinical assessment and decision-making, with diagnostic errors being a key type of incident identified in this category. One intervention focused on improving diagnostic errors, and this related to diabetes diagnosis in people with severe mental illnesses. As you can see, two further potential hazards were identified in this area of research, but were not linked to specific incident typologies amongst the evidence base. These were the adequacy of risk assessment and monitoring, as well as the failure to refer to specialist services, with this second risk relating to external policy context issues. Our fourth area of evidence related to medication safety, with two key types of incident identified in this evidence area. These included adverse drug reactions and medication errors. Interventions included a structured tool aimed at improving the recognition of adverse drug reactions, as well as interventions such as medications reconciliation, focused on reducing medication errors. Suboptimal prescribing safety was raised as another key issue in this area, and the corresponding intervention focused on providing recommendations to providers as well as patient education. Our fifth area of evidence relates to care over time and monitoring and review of different aspects of care. A key area of evidence focused on the failure to monitor for physical health risks, often those associated with prescribed medications. Several key contributory factors were identified in relation to this hazard. These included unclear lines of responsibility, for example, between community mental health teams and GP practices, service user factors such as a reluctance to attend appointments when these were set up, as well as issues around workload and staffing again. Interventions focused on improving the monitoring of physical health risks in this care population employed a range of different strategies. These included co-location interventions which tried to span that primary-secondary care interface, as well as studies which implemented a clear screening protocol and clinical pathway for people that were identified to be at risk. Other interventions again focused around providing education and feedback to providers. A further risk identified in this category concerned the failure to intervene where these risks were identified, but we did not identify specific interventions which targeted this hazard. Our penultimate evidence area related to communication, handover, and multi-agency working issues. 4 key types of hazard were identified in this evidence area, and these concerned the holding of incorrect information about service users by different services that were involved in their care, potential duplication of care activities, non-compliance with the treatment plan set by the other service, or inappropriate task delegation. And again, a series of factors were identified as relating to these issues. We identified just one relevant intervention in this evidence category, which focused on improving the process for handovers within the clinical team. We didn't, however, identify interventions which aimed at improving the processes of handover between teams. Our final evidence area related to the safety of the care system, and this is really about the features of the care system which lead to vulnerability or resilience from harm, including the capacity to prevent deterioration amongst patients. Several key risks were identified in this evidence category, and these included extended delays to care, the adequacy of crisis prevention, and issues with care coordination. And again, workload and staffing factors were identified as contributory factors to each of these issues. In summary, through our review, we've identified 7 key categories of research relating to patient safety problems in community-based mental health services. We carried out a systematic approach to searching the evidence base. However, our findings are limited to services for working-age adults only, and patient safety problems in services for children and older adults must be explored in future reviews. In terms of the evidence base, we found that the studies included made very limited use of patient safety theory. Sometimes intervention mechanisms were not well aligned with the identified hazards or the causal factors. The largest areas of research that we found were related to suicide and self-harm, as well as the failure to monitor for metabolic risks. We also identified some key evidence gaps, and these concerned risk assessment for issues other than suicide, patient involvement in improving safety, and a focus on different safety cultures. This review is the first to our knowledge to explore patient safety challenges in community-based mental health services specifically. We provide a systems-informed picture of safety and identify evidence gaps for future systematic reviews. We also identify priorities for interventions to improve care. Thank you very much for listening, and please do get in touch via email if you'd like to ask any questions or to speak about this further.